Hi and hello from Boston, Massachusetts. Oliver Freudenreich here, or Dr. F, as my patients call me, for the Psychopharmacology Institute for another one of the quick takes. Have you ever wondered how many people with schizophrenia currently smoke? Well, I have, but let me explain. When I trained in the late 80s, it felt like everybody with schizophrenia smoked. At the time, I was working at Butner State Hospital in North Carolina, which was my first job when I came to the United States. It seemed to me as if the whole hospital was arranged around smoke breaks. Now, many articles about smoking prevalence in schizophrenia are a bit old now, and I've always wondered, compared to the old days, how much progress we made in the past decades. So when I saw this publication by Beth Ann in JAMA Network Open about a longitudinal study examining current smoking rates in patients with psychosis in the United States, I decided to take a look and record this quick take for you. Let's start off with a quick warm-up question. What do you think? Take a guess. What percentage of people with psychosis smoke cigarettes today? So pick a number for this prevalence. Is it 10%, 30%, 50%, or even 70%? For some background, let me explain the origins and purpose of this cohort study, which is called PATH study. The acronym stands for Population Assessment of Tobacco and Health. One of the reasons this longitudinal study was commissioned by the federal government of the United States was to provide the FDA with data so they could better perform their regulatory mission with regards to tobacco control and move us to a smoke-free society. Data collection initially included yearly in-person interviews, mostly comprehensive self-assessments to better understand who smokes, which tobacco or nicotine products are used and why, but they also included some biological markers related to smoking. The study participants represent a nationally representative sample that includes not just adults, but also a group of youth aged 12 to 17. And the federal agencies that manage the study are the NIH and NIDA. Now, this study has been going on for over 10 years. The first wave of study assessment started in 2013, and it has gone through 7 assessment waves so far, leading to almost 1,000 publications. The size of this overall cohort has generally been around 30,000 adults and over 10,000 youths in the first wave. Now, the article under discussion provides data from a recent wave 5 from 2018-2019, specifically looking at a subgroup of people, namely those with psychosis. Among the roughly 30,000 adults in the cohort, I mentioned this number earlier, there were about 2.9% of people with psychosis, and that percentage corresponds to about 1,200 people, which is the sample for this report. The mean age was around 30. And here's the answer, based on the PATH study, to my warm-up question from earlier. Remember? What percentage of people with psychosis currently smoke cigarettes? According to the PATH study, the answer is 31% based on the cross-sectional assessment, and this is compared to the cohort of 19%, clearly much higher. And if you do the math, there's an adjusted risk ratio of 1.61. If you look at any tobacco product, not just cigarettes, the prevalence in this sample was even a bit higher, 41% compared to 28%. The data really also show that the picture is complex in the sense that patients with psychosis often use cigarettes plus other nicotine products such as e-cigarettes together. This is an important point for clinicians because you really must inquire about all forms of nicotine products, not just cigarettes. The study also confirmed more severe addiction to nicotine for those with psychosis and some racial disparities. If you picked 10% as your answer, you were really looking at the smoking prevalence in the general population in many states today. In my home state of Massachusetts, for example, 11% of adults currently smoke. You can look at the CDC table to see where your own state lies on the ranking of states in that regard. Now, if you picked 70%, you may be working with a very selected sample with many, many risk factors such as poverty, homelessness, and psychiatric morbidity, plus perhaps substance use. And in such samples, you may get very high prevalence rates, potentially. Here now is the big picture context for this study and the study results. In the United States, smoking is no longer the widespread public health issue it used to be, but it is instead driven by certain subgroups. Let me say this differently. Some subgroups, like patients with psychosis or schizophrenia, remain excluded from what is essentially a tremendous public health success story. And this is due to a variety of vulnerabilities, some psychosocial, but some perhaps even biological. The good news is that on average, most people with psychosis no longer smoke cigarettes. Remember, the rate is below 50%. But the bad news is that a significant minority still does. And here, remember again, about 30%. So we need to continue to focus on this group and get better in helping them to quit smoking or never start, ideally. Now, this would be a completely separate talk, but let me emphasize one point about smoking cessation in patients with psychosis, something I learned from my colleagues in the addiction group in my own hospital here at MGH. Given the severity of nicotine addiction in patients with schizophrenia, and what basically translates into a need for pharmacotherapy to help with smoking cessation, the field has shifted for an opt-out model with regards to smoking cessation. What it means is that basically you offer treatment with medications, specifically varenicline, to help people quit as your default mode, and then you let the patient opt out of this plan. Otherwise, your highly addicted patients with perhaps some biological vulnerabilities will remain ambivalent and never get a good try at smoking cessation. Such a stance de-emphasizes these cycles of change that you may remember, and it really avoids that patients get stuck in this pre-contemplation phase of perhaps quitting down the road, and that point may never come. Here's the clinical bottom line. Smoking is costly for patients with psychosis, both literally and figuratively. Literally because people can use up significant amount of their disability payments, and figuratively because it leads to morbidity and mortality in the form of cancers and lung disease, among many other medical problems. Smoking cessation should be a clinical priority for those patients in your clinic who smoke, which according to this article is currently somewhere around 30% for cigarettes and 40% for any tobacco product, which is much higher than rates in the general population. So please, I urge you, look at your clinical setting and make sure you have a good system to track smoking. And in parentheses, let me add other nicotine-containing products. End of parentheses. Track smoking in all your patients with schizophrenia, and then offer help with tailored smoking cessation. So collectively, perhaps we can remove yet another disparity with regards to health outcomes. Thank you for listening.